Now we start another topic, which is hiatal hernia. But before going into the detail of that, what is a hernia? Hernia is defined as an abnormal exit of a tissue or an organ such as bowel through the wall of the cavity in which it normally resides. I repeat that hernia is defined as an abnormal exit of a tissue or an organ such as the bowel through the wall of the cavity in which it normally resides. Now, there are many types of hernia, and the most common one we are going to name them and we discuss hiatal hernia in detail. Number one, inguinal hernia, present in the inner groin. Incisional hernia resulting from an incision. Femoral hernia, outer groin. Umbilical hernia, belly button, present at the belly button site or outer button. Hiatal hernia, stomach through the diaphragm. So this is the topic which I think will focus it, and this is important from your examination point of view. Is this is the hiatal hernia? Okay, going to touch. Well, we are going to discuss hiatal hernia. It is an abnormal condition in which there is protrusion. Abnormal condition in which there is protrusion of abdominal contents, that is stomach, from the esophageal opening in the diaphragm. It means that it's an abnormal condition where the abdominal content, that is stomach, protrudes through the esophageal opening in the diaphragm. Normally, esophagus passes through this opening from the chest cavity into the abdominal cavity. So, portion of the esophagus is present in the thoracic cavity and small portion is in the abdominal cavity, but stomach is present in the abdominal cavity below the diaphragm. Basic defect is failure of muscle fibers of diaphragm and shortening of esophagus. Must highlight that. If somebody asks you what is the causes or the important causes, then the basic defect is, this is the basic defect, which is failure of the muscle fibers of diaphragm and shortening of the esophagus. Very important. Maybe congenital or acquired. Secondary causes or acquired hernia are due to increased pressure in the abdominal cavity, then forceful sneezing, then frequent vomiting, straining hard while passing stools, hard coughing frequently. Risk factors are degeneration of muscle due to aging, increased intra-abdominal pressure in pregnancy, ascites, abdominal tumors, recurrent regurgitation causing inflammation and fibrosis. Inflammation and fibrosis of what? Of course, that is of the esophagus. Obesity cause decreased muscle, the elasticity of the diaphragm when there is abdominal obesity. Now, mechanism of hiatus hernia formation. When pressure increases in the abdominal cavity, very simple. When pressure increases in the abdominal cavity, increased dilation of opening of diaphragm. When the opening of diaphragm is increased or it's dilated either congenitally or due to aging. This leads to part of the stomach passes through the opening in the diaphragm, and this leads to the formation of hiatal hernia. So very simple, when the pressure increases in the abdominal cavity or when there is dilation of the opening of the diaphragm either due to aging or due to congenitally, part of the stomach passes through the opening in the diaphragm and hiatus hernia results. Now look at this. If you notice this picture and you understand it, I think you don't have to read it, you don't have to pay much attention. This is the gastroesophageal junction. G E gastroesophageal junction. Where it lies? It lies in the abdominal cavity. Right. Next, this is the norm. But when there is sliding hiatal hernia, this gastroesophageal junction comes up into the thoracic cavity along with the part of the stomach. This is the, you can say that these are the hiatal hernia which are sliding type. Simple to understand. Repeat. Gastroesophageal junction circled by red, present normally in the abdomen, and during sliding type, it, whatever the cause, whether it is abdominal pressure increases due to cough, due to sneezing, due to straining, during stools, etc. It goes up in the thoracic cavity along with part of the stomach. Here, this is the paraesophageal hernia. Paraesophageal hernia, and these paraesophageal hernia gastroesophageal junction lies in the abdominal cavity, whereas portion of the stomach, look at that, portion of the stomach comes in the thoracic cavity through the hiatus. These are the paraesophageal or rolling type of hernia. And then these are the mixed type of hernia where, look at that, portion of the stomach along with the gastroesophageal junction, they lies in the abdominal cavity. They are the mixed type of hernia. Now if you understand that, I think the other things will be very, very easy. Sliding hiatus hernia, look at that. This is the normal sliding hiatus hernia, initially form of a bulb type. This is the gastroesophageal junction and portion of the stomach, and again sliding type of hiatus hernia. Rolling type, look at the portion of the gastroesophageal junction remains there, and the bulb type of stomach comes up through the hiatus and lies in the thoracic cavity. Look at that again, the bulb increases. Rolling or paraesophageal hernia. So three patterns we have discussed. Sliding or esophagogastric hiatal hernia, I have already discussed with you. Herniated content appear as a supradiaphragmatic bell due to sliding up on both sides of the esophagus. Very simple. Again, highlight it. It is just like a supradiaphragmatic bell. And what happens is, again, that gastroesophageal junction pulls up into the thoracic cavity along with portion of the stomach, and this is seen on both sides of the esophagus. This is the commonest type and seen in 85% of cases. Then rolling or paraesophageal hiatus hernia. Greater curvature of the stomach rolls up paraesophagally, producing intrathoracic sac. That is, there is the gastroesophageal junction remains in the abdominal cavity, whereas a portion of the stomach or the greater curvature of the stomach rolls up through the hiatus and comes to lie intrathoracically. Occurs in 10% of the cases. And then mixed or transitional hiatal hernia, which are present, that both gastroesophageal junction and greater curvature of the stomach, that comes to lie in the thoracic cavity. Dysphagia, well, it is the difficulty or abnormality of the bleeding. Now this is an important topic from your viva point of view. The examiner, many conditions which leads to dysphagia, and the examiner may ask you what is dysphagia, and the answer is it is the difficulty or abnormality in the swallowing, right? Three phases of swallowing anatomically. One, oral, oropharyngeal, esophageal, and we'll focus our discussion on esophageal. Now, if you answer dysphagia, the other question is, what is odynophagia? Odynophagia is painful swallowing or pain during the swallowing. Dysphagia continues. Any esophageal obstruction causes difficulty in swallowing, known as dysphagia, as I've already discussed with you. Any obstruction causes difficulty in swallowing, known as dysphagia. And the causes are, there are four main types: lesions in the lumen, and among the lesions in the lumen, that is, after swallowing foreign bodies, which are commonly seen in children. Look at that. This is the esophagus, and this is the foreign body. Right, you can appreciate it. This is the foreign body. This is the foreign body, which is present in the lumen and obstructing the passage of the food. Lesion in the wall, and that may be tumors, neoplasm or carcinoma of the esophagus, or fibrosis, which is caused by the chronic inflammation. Once there is fibrosis, of course, it ultimately leads to, and it is the result of the chronic inflammation, and it reduces the lumen of the esophagus, or the lumen of the esophagus is also reduced by carcinoma of the esophagus. Now look at this. This is the esophagus, and this is the neoplasm, cancer, carcinoma, which is protruding into the lumen and obstructing it. Lesion in the wall of the esophagus. Other is something from outside pushing the wall of the esophagus, right? That is esophageal diverticulum, tumors in the mediastinum, for example, invasion by carcinoma of the lung. Now you see, appreciate. This is the esophagus. The lumen, this is the lumen. And that lumen is reduced. Why? Something is pushing from the outside. And sometimes there are neuromuscular disorders which are responsible for dysphagia, lesion affecting the function of the esophagus, like Chagas disease, motor neuron disease, or achalasia. You don't find anything in the lumen, you don't find in the wall of the lumen, you don't find anything outside the esophagus, but there are certain changes which are taking place in the neurons, and the neurons they are ineffective and they do not perform their function. So that is seen as we have discussed in achalasia, Chagas disease, and motor neuron disease. Disorders of the function of the esophagus. Next is esophageal laceration. And when we discuss esophageal laceration, we discuss a syndrome which is known as Mallory Weiss tear or Mallory Weiss syndrome. Now here I give you a hint to remember it. If you say Mallory Weiss syndrome, remember the word M. So the tear is in the mucosa. Mucosa also stands with M, right? So longitudinal tears in the mucosa located near the gastroesophageal junction. Tears may range from few millimeters to centimeters. These tears usually cross gastroesophageal junction and may be present in the upper gastric mucosa. Right? They are present in the upper gastric mucosa. So we have discussed that Mallory esophageal laceration, Mallory Weiss syndrome or Mallory Weiss tear, longitudinal tears. Why? If easy to remember, the tears are superficial because M stands for Mallory, M stands for mucosal or mucosa. Rarely, or sometimes it may extend up to the submucosa, and then the bleeding is hematemesis is much more. We are coming to that. So longitudinal tears in the mucosa located near the gastroesophageal junction. These tears may range from few millimeters to centimeters, and these tears usually cross the gastroesophageal junction, and they are also present in the upper gastric mucosa. Okay, and mostly due to severe racking and vomiting. That is forceful vomiting and racking, and these are the cause of that. Most common in alcoholics. Pathophysiology, well, there is a reflux relaxation of the gastroesophageal musculature before the antiperistaltic contractile wave, which is accompanied by vomiting. That is, the musculature of the gastroesophageal or the gastroesophageal musculature, it is under a relaxation state, and then during vomiting, antiperistaltic contractile waves, they are generated. This relaxation fails during excessive and prolonged vomiting, with the result the reflux gastric contents overcome the gastric inlet, causing the esophageal wall to stretch and undergo tear. So to sum it up, that before vomiting, gastroesophageal musculature is relaxed. When there is vomiting, antiperistaltic contractile wave starts. This relaxation fails due to excessive and prolonged vomiting, with the result the reflux contents overcome the gastric inlet and causing the esophageal wall to stretch, and when the esophageal wall stretches, it may undergo tear, and that tear is longitudinal, and as I told you that it's mostly superficial, and really it can go up to mucosa, but it hardly involves the musculature or the muscle layer. Causes: any cause leading to sudden rise in intragastric or intra-abdominal pressure. Very simple. Severe vomiting with persistent retching, seen in heavy alcoholics. Prolonged hiccups. Trauma to the chest or abdomen. Gastritis. Hiatal hernia. They all cause changes in the pressure and responsible for causing the tear in the mucosa of the esophagus. Symptoms: pain in the upper abdomen, hematemesis, vomiting of blood, melena, blood in the stools. Diagnosis: upper GI endoscopy, You can see the bleeding point, and then there is linear bleeding there is linear bleeding laceration close to the gastroesophageal junction. Look at that. A gentleman carrying a wine bottle after enjoying it have a tear on the right side of the gastroesophageal junction, which may extend to the distal esophagus. There is hematemesis, and then the tear may extend up to the upper portion of the stomach. Tear is incomplete, that only affects, as I told you, mucosa and submucosa. Very important if you remember it. No treatment is required because bleeding stops in 80 to 90% of cases. Esophageal balloon tamponade, if the bleeding is not stopped, then you do esophageal balloon tamponade. Esophageal clips are applied, endoscopic band ligation, and medically proton pump inhibitors or H2 receptor blockers. Complications, very rarely esophagus ruptures. Then another syndrome which is associated with alcoholism is BOERHAAVE'S syndrome, and again it is associated with hematemesis. Now, this lesion in this condition or in this syndrome, lesion is above the gastroesophageal junction. If you see this word bore, it means the lesion is through and through. That here in the previous case, M was there, so lesion was limited to mucosa. Here bore is there, so you are doing a bore through the mucosa, submucosa, and muscular coat. So the lesion is through and through, and the lesion is above the gastroesophageal junction. Full thickness tear, we can say transmural tear or perforation of esophagus. Around 5 centimeter above the gastroesophageal junction, left posterolateral side of the esophagus located, mostly the lesion is left posterolateral side of the esophagus. Increased intraesophageal pressure. Well, in the Mallory Weiss syndrome, there was increased pressure either in the stomach or in the abdominal cavity, but here this BOERHAAVE'S syndrome is increased esophageal pressure. Okay, presentation is chest pain, hematemesis, and subcutaneous emphysema, because there is rupture of the musculature of the muscle wall of the esophagus, by which air goes into the subcutaneous tissue, producing crackling sounds, and these crackling sounds are due to the presence of air bubbles around the sternum or mediastinal region. Look at that. BOERHAAVE'S syndrome, chest pain, of course, shock is due to excessive bleeding, subcutaneous emphysema, you can see that, and then complete rupture in the lower thoracic esophagus. Also, I don't want to discuss in detail of that Heman sign, that is crunching sounds on the auscultation, that is due to the presence of air in the mediastinum. But there is a triad which is known as Meckler's triad, and that is chest pain, subcutaneous emphysema, and vomiting. Vomiting. So very simple that you can I should write it in a better way that you can understand that. That is Mackler's tried. That is, I think, Mackler's tried three things. Tried means three things. That is chest pain, subcutaneous emphysema, and this is vomiting. Now, as I told you that we discussed two previous topics, and those two previous topics of esophageal laceration includes Mallory Weiss syndrome and then BOERHAAVE'S syndrome. Both have got uh, hematemesis, and that is painful hematemesis. But in esophageal varices, the hematemesis is painless hematemesis. They are dilated, esophageal varices are dilated tortuous vein within the mucosa or submucosa, and these veins are in the lower third of the esophagus and proximal to the stomach. The location is they are in the lower third of the esophagus and proximal to the stomach. They are basically, they are, look at that, dilated tortuous veins within the mucosa and submucosa. And these veins are in the lower third of the esophagus and proximal to the stomach. Secondary to portal hypertension, most important thing, which is due to impaired blood flow through portal system and liver. Commonest cause is cirrhosis. Small varices never bleed, but large varices, when rupture, there is massive, again, I must say, I must underline this word, painless hematemesis, which may be fatal. Complication is fatal hemorrhage. Tortuous dilated veins within the mucosa and submucosa present in the lower third of the esophagus and proximal to the stomach. Secondary to portal hypertension, which is due to impaired blood flow through the portal system and the liver. Cirrhosis is the commonest cause. Small varices do not bleed or bleed very less, but large varices, when ruptured, there is massive painless hematemesis. Complication includes fatal hemorrhage. Band ligation, sclerotherapy, or balloon tamponade is the treatment which is carried out. Look at this esophagus, this is stomach, this is stomach, this is esophagus, and this is the varices. You can see that at the lower end of the esophagus, showing linear dark blue submucosal dilated veins known as varices, pointed by the arrow, and also I've encircled them. Again, this is the varix shown by the circle, white circle and black circle. Another varix near the gastroesophageal junction, that is dark red black because it has been bleeding. The plexus of veins also involves some of the upper part of the stomach, but generically we call them esophageal plexus of veins. The bleeding referred to as esophageal varicose bleeding. Look at that, bleeding is there. Look at the dilated veins. All the dilated veins. Esophageal varices. Well, this is the histology of that dilated vein. May rupture, and in the surrounding there is inflammatory cellular infiltrate. You can see this is all inflammatory inflammation. Right. Varicose rupture, which leads to hemorrhage into the lumen or the esophageal wall, along with ulceration and necrosis. That is this is the necrose part. Necrosis is there.